Good morning, everyone. I'm Dr. Asima Farooq. I'm delighted to welcome you to today's lecture on health data ethics and policy. First, I want to sincerely thank the incredible team at Universal Digital Health University for their support and dedication in making this session possible. This lecture will help us understand how to use health data responsibly, balancing innovation with privacy, individual rights, and public goods. Health data ethics is a digital frontier where medicine meets the ethics, laws, and human values. In this lecture, we will understand the core ethical principles that guide how health data should be collected, shared, and reused, recognize regulatory and legal frameworks like GDPR in Europe and HIPAA in the US that govern the data use, critically evaluate the ethical framework for the secondary use of data, meaning when data is used beyond its original purpose, like for research, and finally learn to write a short policy brief. It is a powerful tool to communicate ethical recommendations to decision makers. So, this session is not just theory, it's designed to help you apply ethics in real life research, practice, and policy making. Why ethics matters in health data? Let's pause and think, why do we need ethics in health data at all? Imagine your fitness app knows your heartbeat, and now an insurance company does too. You are getting calls from an insurance company hinting at your heart rate, urging you to buy their insurance plan. Is it legal? Maybe, but is it ethical? That's the question we will answer today. Every time a patient visits a hospital, wears a smartwatch, or joins a health app, a huge amount of personal data is created. This data, if used ethically, it can save lives, improve health systems, and power new discoveries. But if misused, even unintentionally, they can lead to harm, discrimination, or loss of trust. Trust is the foundation of healthcare. When people know their data is safe, private, and used for the right reasons, they are more likely to participate in research and public health programs. Ethics protect three key things: privacy, autonomy, and justice. Privacy, because health data reveals the most intimate details of a person's life. And autonomy, meaning individual should have control over how their data is used. Justice is ensuring that data benefits everyone, not just a powerful group or the rich countries only. For example, during COVID 19, data sharing helped track infections and develop vaccines. But it also raised questions that who owns the data? How do we prevent its misuse? So, ethics is not about restricting the progress, it's about guiding innovation responsibly so technology and humanity move forward together. Now, let's look at the backbone of all ethical decision making. There are the four core principles from the Belmont Report and the Declaration of Helsinki. Respect for person, that is autonomy. Everyone has the right to make informed decisions about how their data is used. Consent should be meaningful and it must not be just a checkbox. Then, beneficence, use data to do good, to improve care, discover treatments, and advance health systems. Non-maleficence, do not harm. Data misuse, leaks, or biases in algorithm can cause serious harm. So, minimizing risk is very crucial. Justice is fairness in access, participation, and benefit. We should ensure data from all communities is used equitably, not just from the wealthy or the well connected populations. A good memory tip for this is ABNG: autonomy, beneficence, non maleficence, and the justice. These principles may sound simple, but applying them to digital data where information can be copied, sold, or combined is very complex. That's what makes the modern health data ethics so interesting. Health data comes in many forms, from hospital records to mobile apps. Let's divide it into the two big categories. One is the primary use, and then is the secondary use. Primary use is when data is used directly for patient care, like diagnosis, treatment, managing a patient. And the secondary use when the same data is reused for other purpose, like research, public health monitoring, or a policy making. Examples of data are the electronic health records, national disease registries, wearable devices, genetic and genomic information, insurance claims, social detriment data. These are all just few examples. Each type raises different ethical concerns. For example, genomic data can reveal information not only about one person but about other family too, their families too. So, understanding what kind of data we are handling and for what purpose helps determine which ethical safeguards we must apply. When we face ethical dilemmas in health data, say deciding how to use patient information or balancing privacy with research needs, we need a structured way to reason through what is right and fair. That's where the ethical reasoning frameworks guide us. The first approach is principlism. It rests on the four foundation values that we just studied: autonomy, beneficence, non maleficence, and justice. It is the language of modern bioethics, used by the ethics committee and researchers to evaluate real world cases. For example, ensuring a patient's consent, autonomy, doing good, beneficence, avoiding harm, non maleficence, and distributing benefits fairly, justice. The second is utilitarian reasoning. Ask a simple but powerful question: what action leads to the greatest good for the greatest number? It is often applied in public health, vaccination campaigns, resource allocation, where population benefit takes priority. Yet it can be controversial because it may sacrifice individual rights for the collective good. Next is the deontological ethics. It shifts the focus from outcomes to duties and principles. It tells us do the right things because it's right, not because it brings the best result. For example, we must never use patient data without consent, even if doing so could advance valuable research. It's about respect for the human dignity and moral rules that should not be broken. Then we have care ethics, which adds the human touch. It reminds us that ethics is not only about logic, but also about empathy, trust, and relationships, especially when working with the vulnerable populations or within the communities. And in reality, ethical reasoning is rarely one dimensional. A policymaker designing a national health data registry might use utilitarian thinking to maximize benefit, principlism to ensure fairness and consent, and care ethics to maintain trust. So, ethical reasoning is not about choosing one framework, it's about integrating them wisely to make the decisions that are both morally sound and humanly sensitive. Strong data ethics is impossible without strong governance. Governance means the structure, rules, and accountability mechanisms that ensure health data is used safely, lawfully, and fairly. Its principles are purpose limitation. Data must only be used for the purpose it was collected. Data minimization. Collect only what is necessary. Then is the transparency. Data subjects should know who is using their data and why. Accountability. Organizations must demonstrate compliance and responsibility. Fair principles. Data should be findable, accessible, interoperable, and reusable. Five safe models are the safe projects, people, data settings, and outputs. We will further explore it in the coming slide. Example is the UK's Office for National Statistics applies the five safe model before granting researchers access to any dataset. This model helps ensure public confidence and research integrity. Good governance builds trust, and trust is the currency of modern data science. In legal and regulatory landscape, the ethical handling of health data is inseparable from law. Let's review some of the most important legal framework. In Europe, the GDPR, that is the General Data Protection Regulation, is the gold standard. It emphasizes individual rights such as access, correction, erasure, and objection. And it requires the lawful basis for every data processing activity. In the United States, we have HIPAA, Health Insurance Portability and Accountability Act. It focuses on protecting protected health information within the healthcare systems. It has strict rules on data sharing, but unlike GDPR, it mainly covers the healthcare entities rather than all the organizations. Emerging now is the European health data space. which aims to harmonize data sharing for healthcare and research across the Europe. It promotes data reuse while ensuring privacy and interoperability. Other frameworks include national research ethics law. The common rule is in the US and OECD guidelines internationally. So ethics and law must work hand in hand. Law sets the minimum while ethics aim for the ideal. True professionals go beyond more compliance. They act out of the moral responsibility. Consent model for secondary uses: when health data collected for one purpose is reused for another, as we have discussed before, that we use it for the research purpose or for policy making. So consent becomes a key ethical and legal question here. We have several models. One is the specific consent given for a clearly defined purpose. This protects autonomy but limits the flexibility. Then is the broad consent. Participants agree that their data may be used in future related research. It supports innovation but requires strong governance safeguards. Dynamic consent, a modern digital model that allows participants to adjust their consent over time using only online platforms. It's interactive and transparent but resource intensive. Fourth one is the implied or opt-out consent, often used in large-scale public health databases when individual consent is not feasible. This model demands rigorous oversight and justification. The ethical test is whether participants' expectations are respected or not. For example, if someone shared data for hospital care, using it for insurance pricing would violate the trust. Thus, the goal is not just to collect consent, it is to earn and maintain consent through transparency and respect. There are certain risks associated with the secondary use. For the risk assessment, when using the health data for secondary purpose, such as research or AI model training, we must carefully assess its risk before access is granted. A sound ethical framework demands that we must evaluate the sensitivity of the data. For example, the genetic, mental health, sexual health data carries the higher sensitivity. The probability of re identification, especially when data is linked across multiple sources. The contextual risk such as potential discrimination, stigmatization, or misuse by the third parties. That's where the data protection impact assessment comes in. It is a structured tool to document risk and mitigation strategies. They ask what could go wrong, how serious is the harm, what safeguards are in place. Its example is in 2020, the UK's national health system was criticized when it shared patient data with an artificial intelligence company without proper DPIA or consent. Although the intent was to improve the kidney care, the lack of transparency led to a major public backlash. It taught the world that even noble aims can fail ethically if risk assessment is weak. So, the key principle is anticipate risk before they occur, not after the damage is done. Let's see how modern data science protects the patient privacy while enabling ethical research. Health data is one of the most powerful tools for research, but also one of the most sensitive. Every medical record holds personal stories, identities, and conditions that must be protected. That's where de identification and anonymization come in. These are ethical and technical process that makes health data safe to use without violating anyone's privacy. Let's understand the major methods used in health data protection. First is the de-identification. This is the umbrella process of removing or modifying personal information so an individual cannot be directly recognized. It includes techniques like pseudo-anonymization, masking, and key anonymity. Then is the anonymization. It goes one step further. Data is modified here, so it can never be traced back to that specific person. Once anonymized, you cannot re-identify the individual even if you try linking it with other databases. Pseudo-anonymization. Here we replace the identifiers like the name or ID with the artificial codes or the random numbers. A hidden key exists in a secure location So, authorized researchers only can reconnect the data if absolutely needed. For example, patient ID is 0029 instead of the Dr. Aisha Khan. Fourth one is the key anonymity. This method ensures that this method ensures that each person is in the dataset looks like at least K others. For example, instead of showing age 43, data might be grouped at 40 to 45. This prevents anyone from being singled out. Masking hides the sensitive parts of data, like showing only the first few digits of a phone number or replacing the exact birth date with an age range. Instead of 10 year of age, we will say it's from 7 to 12 year of age. Sixth is the randomization or the noise addition. Sometimes small random changes are added to data values to prevent anyone from matching them with real identities while keeping the overall data set statistically valid. Re-identification and linkage risk. Even after de-identification, data is not always 100% safe. If someone combines your dataset with another, say hospital records with social media or government data, individuals could still be re-identified. This is called a linkage threat. So researchers must always evaluate the risk of re-identification before sharing the data publicly. Regulatory perspective is different countries have laws defining what count as de-identified. For example, under HIPAA privacy rule in USA, a dataset is considered de-identified if all 18 identifiers, such as name, phone, address, social security number, etc., are removed, or if an expert certifies that the chance of re-identification is very small. Similarly, under GDPR in Europe, anonymized data falls outside data protection law, but pseudo-anonymized data does not because it can still be traced using the hidden key. WHO and OECD advocate anonymization before data sharing. Actually, ethical compliance is equal to the legal plus moral obligations. And benefits of ethical compliance is it protects privacy, enable global health research, build public confidence, prevent misuse of sensitive information, and ethical data creates a sustainable digital health system for you. And what are the risks if we ignore it? First of all, is the breach of confidentiality, legal penalties, public mistrust, discrimination or stigma exposure of mental health or HIV data. Practical application in research apply before secondary data analysis. Health policy modeling, artificial intelligence or machine learning training or WHO data sets. So researchers must never share identifiable data publicly. Let's move from theory to reality. Health data ethics is not just about frameworks and guidelines, it's about real lives and real consequences. Over the past few years, several global cases have shown what happens when organizations fail to protect privacy or ignore ethical responsibilities. We will look at three major incidents: Cambridge Analytica, the Sign Health breach, and the Sing Health breach, and the NHS DeepMind case. To understand what went wrong and what lessons they teach us, in 2018, Cambridge Analytica UK USA case arose. Most of us have probably heard of this scandal. It started as an innocent looking personality quiz on Facebook, but behind the scenes, data from over 87 million users was harvested without consent and used for political profiling during elections in the US and UK. This incident was a wake up call for the world. Even though this was not a healthcare dataset, but it is one of the most powerful examples of how digital data, even if called de identified, can be manipulated and misused. It reminds us that consent, transparency, and accountability are non negotiable in data ethics. If people don't trust how their data is handled, they stop sharing it, and that breaks the foundation of ethical research. Even so called de identified data can be misused. Consent and purpose limitations are essential. The second case is Singh Health breach that was in Singapore.
Just months later, in 2018, Singapore faced its largest ever cyber attack, the Singhealth data breach. Hackers infiltrated the health system and stole the personal records of 1.5 million patients, including those of the Prime Minister himself. This was not just a technical failure, it was an ethical one too. The attack revealed weak cybersecurity practices and insufficient access control. It showed that protecting patient data is not only about following regulations, it's about upholding human dignity and trust. So it means that strong cybersecurity and role based access control are not optional, they are ethical obligations. Then in 2020, the UK's National Health Service collaborated with Google's DeepMind to develop an AI tool that could predict acute kidney injury. The idea was promising, using artificial intelligence to save lives. But here is what went wrong. Patient data was shared without explicit consent, and no data protection impact assessment was conducted. Even though the goal was noble, it violated key ethical principles: autonomy, the right of patient to decide how their data is used, and accountability, that is, the duty to assess risk before sharing sensitive data. This can remind us that good intentions do not override ethical responsibilities. So it means that innovation must never bypass privacy or informed consent. Ethics must guide technology, not the other way around. So these cases teach us a powerful lesson, whether it's a political profiling, a hospital breach, or an artificial intelligence innovation. Ethical data practices are what protect trust, integrity, and human dignity. Technology can save lives, but without ethics, it can also harm them. That's why every researcher, policymaker, and data scientist must think ethically before thinking technically. In previous slides, we have talked about a lot about the data protection impact assessment. Let's see what is it. Before you start any medical research or digital health project, imagine doing one simple thing, that is a safety check. Just like doctors don't begin a surgery without sterilizing instruments, data professional should not touch personal data without checking for the privacy risk. This safety check is called a Data Protection Impact Assessment or DPIA. It is not just a formality or paperwork, it's your ethical seatbelt before you drive into the world of health data. So, what exactly is a DPIA? It's a systematic process that helps you identify, assess, and minimize privacy risk when handling personal data, especially the sensitive health information. Think of it as a risk radar. Before collecting or sharing any data, you scan for the potential dangers. Could someone's identity accidentally be revealed? Is there a chance of a data leak? Are you storing more data than necessary? The DPIA makes you think through all of this before harm happens. It is a proactive protection, not a reactive damage control. Now, why is this so important? First of all, it protects individuals' privacy. When you handle patient records or mental health data, people are trusting you with their stories. DPIA ensures that trust is not broken. Identify potential risk. For example, you might realize your dataset includes indirect identifiers like rare diseases or small region zip codes that could re identify someone. So, catching this early allows you to anonymize or limit the access. The third is it is required by the law in many regions. Under the GDPR in Europe, a DPIA is mandatory. Whenever your project involves a high risk processing, such as health data, biometrics, or AI analytics, and it is not just Europe, other countries are also adopting the similar frameworks too. So, skipping a DPIA is not just unethical, in some countries, it can also be illegal. We understand what a DPIA is. Let's see how actually to do it. Think of it like performing a safety inspection before a flight. You don't want to discover a problem when you are already in the air. So, in data ethics, a DPIA helps you find privacy risk before a single record is shared or analyzed. So, here is a 5 simple step guide that every researcher or organization can follow. Describe the data and its purpose. Step 1 is what kind of data are we collecting and why? Is it patient records, mental health assessment, or a genetic data? And most importantly, what's the goal of collecting this data? If you cannot clearly explain why that data is needed, maybe you should not collect it at all. Example is we are using anonymized patient data to develop an artificial intelligence model that predicts kidney disease risk. That clarity builds both ethical integrity and public trust. Second is assess whether the data is truly necessary. Do you really need full medical histories, or would aggregate statistics can work? Ethically, the less data you collect, the lower the risk. This step forces you to ask, is this data collection proportionate to the problem we are solving? Because ethical research is efficient research, it uses only what is needed. In step 3, we identify the possible risk. Could the data accidentally identify someone? Could it be misused, leaked, or even cause discrimination? For example, if insurers got access to it. This step is where you put on your detective hat and look for the weak spots. De identification, data misuse, bias, and unauthorized access are all red flags. You don't need to be a cybersecurity expert, but just someone who can spot where harm might occur. Last step is the plan your safeguards. This is your privacy armor. Decide what technical and organizational measures will protect your data. Use the encryption for storage and transfer. Apply access controls so only authorized people can view sensitive data. Use anonymization or pseudo anonymization. So even if data leaks, identities stay safe. Good ethics is not about trusting people. It is about building system that don't require blind trust. And in the end, you have to document and review everything. Write down what data you are using, what risk you identified, what safeguards you have added, then review it regularly, especially if the project changes or new data is added. This step creates transparency and accountability, the two pillars of data ethics. If regulators or patients ever ask, you can show, yes, we thought through the risk, and here is how we protected you. The real world example of this case is imagine a hospital wants to share patient record with an AI company to predict kidney disease. A DPIA would ask, has the hospital obtained patient consent? Could anyone re identify a patient from the data? Are there strong encryption and access control in place? By walking through these questions before data sharing, the hospital can spot ethical problems early and fix them before harm occurs. So, in short, a DPIA transforms reactive damage control into proactive protection. It is not just a checkbox, it's a mindset. It helps us collect only what's necessary, protect what's sensitive, and prove that ethical responsibility is at the heart of every data driven project.